Welcome to this explainer. Today, we're looking at a truly fascinating paradox of human anatomy. We're talking about the vermiform appendix. It's this tiny, seemingly unassuming little structure in the body, mostly famous for doing absolutely nothing. Yet, it's responsible for one of the most common emergency abdominal surgeries worldwide. It is literally capable of triggering a massive, life-threatening crisis out of nowhere. To understand how to catch this emergency before it's too late, we really have to look closely at both the microscopic structure of the tissue itself and the high-tech ways we visualize it in real time.
So that brings us to our central question. How exactly do we diagnose a 6mm medical emergency? Because accurately diagnosing acute appendicitis, well, it doesn't rely on massive, obvious red flags. Instead, it relies entirely on a clinician's ability to identify tiny, incredibly precise millimeter-scale clues hidden deep within the body. It takes a highly trained eye looking at stark, high-contrast imagery to spot the danger.
Okay, let's dive right into this. Here is our roadmap. We'll start with the microanatomy of the appendix, move on to normal ultrasound findings, then cover diagnosing acute appendicitis, and wrap up with recognizing severe complications. Let's get to it.
Section 1, Microanatomy of the Appendix, establishing the anatomical foundation. Before we zoom all the way in under the microscope, we have to start macroscopically. The appendix, it doesn't just float freely in the abdomen. It directly arises from the cecum, which is basically the very beginning of your large intestine. Knowing exactly where it anchors, that's step 1 for literally any diagnostician.
Now, when we take a cross-section of this tiny structure, a super intricate architecture is revealed. Just like the rest of your intestine, the appendix is composed of 4 distinct layers. Moving from the inside out, we have the mucosa, the submucosa, the muscularis propria, and finally the outer serosa. Its structure perfectly mimics the intestinal tract that it branches right off from.
And each of these 4 layers has a highly specific job to do. The innermost mucosa contains intestinal glands. The muscularis propria acts as the engine, producing that peristaltic movement. The serosa acts as the protective outer cover. But the submucosa, that is where things get truly fascinating. It contains abundant lymphoid tissue. There's a pretty great irony here, right? An organ mostly known for being totally useless is actually packed with this hyperactive immune tissue. This prominent lymphoid tissue is a distinctly important, defining characteristic of the appendix itself. Moving right along to Section 2, Normal Ultrasound Findings, Knowing Your Baseline. Because in medicine, to accurately spot the abnormal, you first have to deeply and thoroughly understand exactly what a normal, healthy baseline looks like. So, when a sonographer looks at a healthy patient, they expect to see a few foundational visual cues. A normal appendix appears as a tubular structure. Crucially, it is blind-ending. What that means is, it doesn't loop back into the digestive tract, it just stops. It arises from the cecum, as we already established, and it retains that characteristic layered wall appearance we just talked about in the microanatomy section. It's almost like a tiny layered dead-end street. But hey, visuals are only half the battle, right? We also need hard measurements. 6 millimeters. This is the absolute magic number you need to commit to memory. When a sonographer measures the outer diameter of the appendix, finding it to be 6 millimeters or less usually means you are looking at a perfectly healthy, uninflamed appendix. So, the crucial point here is how this structure behaves under physical pressure. A defining trait of a healthy appendix is that it's compressible. When the sonographer applies what's called graded compression, basically pressing the ultrasound probe down into the abdomen, a normal 6mm appendix will actually flatten and compress right under that mechanical pressure. Now we reach Section 3, Diagnosing Acute Appendicitis, the Pathological Pivot. This is the exact moment in our explainer where that healthy, normal baseline we just learned about is completely disrupted by acute inflammation. The contrast between normal and acute is incredibly stark. As we said, a healthy appendix is compressible and measures 6 millimeters or less. But in acute appendicitis, the structure crosses that dangerous 6 millimeter line, becoming severely enlarged. And because it's so swollen and inflamed, with all this pressure building up from the inside, it becomes completely non-compressible. No matter how much graded compression the sonographer applies, it simply will not flatten out. Diagnosticians actually look for a critical triad of symptoms to confirm appendicitis. First, that enlarged size, greater than 6 millimeters. Second, that non-compressible, thickened wall. But the third one is incredibly fascinating: echogenic periappendigeal fat. Now, echogenic just means bright on an ultrasound. The inflammation in the appendix actually causes the surrounding fat to react, making it notably bright and highly visible on a Stark scan.
And there's another vital layer to this whole diagnostic process, Doppler ultrasound. Turning this feature on reveals increased blood flow. That increased flow is the body's direct, localized response to the inflammation, and it provides this brightly colored, undeniable clue popping off the screen to really confirm acute appendicitis.
Which brings us to our final stage, Section 4, recognizing severe complications. We are moving well beyond simple inflammation now. Failing to assess the appendix thoroughly at this stage can lead a patient into much more dangerous territory.
A really skilled sonographer isn't just looking for the inflamed appendix itself. They are actively hunting for severe additional findings to prevent life-threatening events. They're looking for an appendicolith, which is a calcified stone literally blocking the appendix. They checked for periappendiceal fluid leaking out around the area. They scan for enlarged lymph nodes nearby. And most dangerously, they check to see if an abscess has formed, which completely changes this from a routine surgery into a complex, high-risk medical crisis.
To ensure absolutely none of those severe complications are missed, sonographers rely on a strict 3-step ultrasound scan technique. Step 1, find the cecal origin to anchor your orientation. Step 2, assess the entire length of that tubular structure. And Step 3, and I can't stress this enough, this is crucial, you must reach the blind-ending tip. Evaluating the appendix all the way down to its very end is the only way to guarantee you haven't missed a hidden pocket of severe inflammation.
So we've gone from microscopic lymphoid tissue all the way up to high-contrast clinical diagnostics. I want to leave you with this. Next time you hear the word appendicitis, will you picture the blind-ending tip or the crucial 6 mm threshold? Think about it. Thank you so much for joining me on this explainer. I really hope this gives you a whole new appreciation for the tiny, millimeter-scale clues that solve massive medical mysteries.